Good evening, everyone. A very warm welcome to all of you in Oncology Classroom evening session. This evening, we are going to have a very interesting talk on evolution of radiation in Hodgkin lymphoma. And this lecture will be delivered by Dr. Rahul R. Parikh. Dr. Parikh is the director of Laurie Proton Therapy Center and is also Associate Professor of Radiation Oncology at Rutgers Cancer Institute of New Jersey, which is part of Robert Wood Johnson University Hospital, one of the largest university hospitals of US. Dr. Parikh also holds several leadership roles within committees in ASTRO, steering committee of ILROG, and on several committees of Particle Therapy Cooperative Group, ASCO, and American Radium Society. He is also an active member of several cooperative groups, which includes RTOG, Proton Collaborative Group, and Children's Oncology Group. Just to add to this, Dr. Parikh was my fellowship mentor when I went there as an international fellow for Precision Radiation Oncology and Proton Therapy Fellowship Program. Let us all welcome Dr. Parikh. Thank you, Dr. Parikh, for accepting this invitation and finding your time among your extremely busy schedule. May I now request you to please take over the session and start your presentation. Thank you once again.
Dr. Mandel has, he was actually one of our first fellows in our fellowship that helped sort of kind of expand the training of international radiation oncologists. And, just one moment here. Okay, as I share the screen. Just a second. Do you see the screen there?
Yeah.
Okay, great. It's really, what he's put together here, and I see 150 people attending this conference. So, I'm really impressed with the just the curiosity, international curiosity, and the kind of dedication to learning. These are some tough times for everyone. I hope everyone is doing their part. But I think what we've learned through, and that's a whole different lecture through the COVID times, is that cancer doesn't stop for COVID, and everyone here, treats cancer every day, and nothing's really stopped. And so I hope everyone's well and is able to continue their practice. And so I just hope this can hopefully supplement your practice in any way and shape. I'll try to give an overview of the role of radiation and evolution in Hodgkin lymphoma. This is really just for Hodgkin lymphoma. I've kind of expanded this for the purposes of today's talk. We can talk for hours about non-Hodgkin lymphoma, but today is really, and some of the treatment techniques and radiation techniques that we talk about, we can extrapolate into the non-Hodgkin world. Dr. Dodo mentioned that we use a lot of proton therapy here, but you don't need proton therapy to treat lymphoma successfully. So let me get started here. And if there's any issues with seeing the screen, just let me know. Let's try to keep in mind some of the objectives that we have as we sort of approach patients with Hodgkin lymphoma. There's some classification and criteria that we should use when we approach these patients. We should incorporate them into our staging or workup. It's known as the Lugano classification and Deauville criteria. So radiologists should be very familiar, and if they're not in your practice, you should make them very familiar with Deauville criteria. We'll talk about that. We'll sort of review where does radiation play a role in the management of Hodgkin lymphoma within the combined modality therapy approach or chemotherapy alone approach for all the early stage disease. And we'll really focus on early stage disease today. We'll touch on advanced and relapse disease because we do end up seeing these patients quite a bit. And then we'll talk about modern techniques. This is probably the most exciting portion for the radiation oncologists in the group, modern radiation techniques using involved site radiation and some treatment planning tips. So we should continue to appreciate this older, this historical but yet still relevant slide of the anatomic regions where we suspect patients have involvement of lymphoma, and this is really for staging. And although it's 40 years, almost 40 years old, it remains unchanged in the Lugano classification. So just keep in mind, these are pretty straightforward, all these sites of involvement, of nodal areas of involvement. This is where it can get a little bit tricky as you look across various stage groups, but keep these in mind. Keep this, very handy as you stage patients. And there have been some changes about 2 years ago with the HACC staging. The modifications, luckily for liquid tumors like Hodgkin lymphomas, have not changed drastically. So our trainees, and if you're a trainee, it hasn't changed. With solid tumors, there's hundreds of more pages in the HACC staging manual. But for lymphoma, it's really has still remained 1 and 2 being on the same side of the diaphragm, either single or more, 2 or more lymphatic regions involved, and then stage 3 on both sides of the diaphragm, and 4 with disseminated disease. One thing to keep in mind that for disseminated or diffuse stage 4 disease, it's very different than extranodal extension of disease. So there's distinct involvement of the liver, lung, bone marrow, CSF. Is not direct extension that we often see with perhaps mediastinal disease extending into the lung, which would not be stage 4. Always remember the B symptoms and extranodal disease. And these I left for your, a lot of this is for your reference. Is for your reference, where some of the subscripts and different connotations have been removed or added, largely because of prognostic significance or lack thereof. Really, the PHS X-ray is has only a historical perspective, and all patients with lymphoma, either for staging or for radiation planning, should get at least 3-dimensional diagnostic workup. So when we look at how to approach these patients for workup and staging, we should keep in mind the Lugano classification. It's a few years old now, and there's probably a good opportunity for updating this. But in addition to the historical history and physical and laboratory workup, PET-CT, FDG PET-CT has really become the standard for these FDG avid lymphomas. Response assessment, we'll get to that in a minute. Want to force a 5-point scale because, as you'll see, the data follows all of the standardized response assessment. And in follow-up, we really discourage routine surveillance scans, at least functional imaging, especially for those patients with early-stage Hodgkin lymphoma that have undergone complete remission. And then bone marrow biopsy. In our practices, we've largely replaced this with PET scan, especially if you're able to obtain this at the time of diagnosis. So one thing that radiation oncologists really should remember, and because it does make a difference for our treatment-specific indications, is what is bulky and what consists of bulky disease. Now, the pediatric Hodgkin lymphoma studies have used a different classification that has been used for many years, so this has some validation substance. But per the Lugano classification for Hodgkin lymphoma, it is clear across all of the staging of the risk classification groups and study groups that 10 centimeters is clearly a bulky disease. But we should keep in mind a nice study published from the MSKCC and some Dana-Farber patients showed validated in early stage classical Hodgkin lymphoma patients that even 7 centimeters is a reasonable cutoff point for bulky disease. And to remember, this is not just the maximal transverse diameter, which would be represented in the historical PHS X-ray, but really also the coronal diameter. So that has been a validated size criteria, and it speaks to the bulk of disease rather than just one-dimensional measurement. And when we look at other non-Hodgkin lymphoma, just keep this in mind, and we won't discuss this today, but perhaps for future reference. And I think what will become more relevant in the future is not just an anatomic and functional imaging, is actually metabolic tumor volume. And there's a nice study published from the MD Anderson group about a year and a half ago about using radiomic, PET-based radiomics and features to identify patients who may be at high risk for relapse disease, which is really what bulky disease means. And so when we talk about Deauville criteria, I think we should commit this to memory, and all the trainees and practitioners should have this to memory. And what is a Deauville criteria? And I would encourage every practitioner, medical oncologist, or radiation oncologist to discuss this with their radiologist if it is not always reported, and we should always keep this in mind. And because our recommendations for adding consolidative therapy or accelerating or adding more systemic therapy may be based on this. So what we consider a PET negative score of 1 to 3 is really relative to the uptake of the index lesions to the mediastinum and liver. So less than or equal to mediastinum, and then between mediastinum and liver would be 3. And then 4 and 5 are those patients who have unfavorable response. And these are, and so I've highlighted in the studies that we will discuss for de-escalation studies, 3 to 5 were actually considered positive. It was really to limit excess relapses and perhaps be more conservative. But just keep these in mind when you're making treatment recommendations, and follow patients with restaging interim assessment. And not all PET-CT is the same. And as we've realized this in our practice, and this is a very important concept that was brought actually to my attention from Professor McHale from London Hospital. What he had discovered through their work is that, for example, you have a patient here with initial staging PET-CT scan. You see the right low neck supraclavicular node, and using different reconstruction algorithms, you can actually change the Deauville score. So one of the more widely used reconstruction algorithm is known as OSEM, and you see here the patient has a score of 2, which is less than mediastinum. But if you use a different reconstruction algorithm, and it's essentially meant known as Q-clear, it's sort of meant from the radiologist standpoint to be more sensitive, and shows here that it is actually higher than liver, and this Deauville score could be a 4. So when your patients may travel to other centers, aside from the one where the staging is done, the reconstruction algorithm can make a big difference in your interim assessment Deauville score. So to be aware of this score, and you can perhaps even ask your radiology department which reconstruction algorithm is used during the PET-CT scan. So let's focus on early stage classical Hodgkin lymphoma. This can be found in the NCCN guidelines, and this is really an example of all of the unfavorable risk factors across all of the study groups. So here's a German Hodgkin study group, the EORTC, NCIC, and NCCN. And you see here there's different risk factors that may or may not be included. The ones that are most commonly included are systemic B symptoms, mediastinal mass. This is the mediastinal mass ratio or maximal tumor ratio in the mediastinum, really over a third of the mediastinum involved, or 10 centimeters for bulky disease per NCCN, extranodal lesions, and number of nodal sites. Now, remember, and we'll come to this after when we dissect these studies, is the definition of the lymph node regions. We saw the Ann Arbor staging, and then the EORTC and German Hodgkin study group have a slightly different definition for the nodal sites, and largely, as we mentioned, in the supraclavicular, cervical, axillary, subpectoral, and in the chest. This is really just for your reference. For advanced stage classical Hodgkin lymphoma patients, we look at some of the international prognostic score. Our counterparts in hematology oncology help use this to prognostically classify these patients and their 5-year overall survivals and progression-free survivals. So as we follow through the guidelines, I sort of took the NCCN guidelines and divided up, and you see here, as if you're a radiation oncologist, if you've been practicing for many years, we never really saw involved site radiation as one of the exact treatment options. It was always plus or minus radiation, and it took many years of effort to incorporate radiation as a standard of care in many of these studies, because of these studies and into the national guidelines. So this is a good reference, and we can often use it in our tumor boards and other multidisciplinary settings. But here there's really no such thing as very favorable, but I like to use this as those patients who we think have the lowest chance of recurrence after minimal therapy, and that minimal therapy can be just 2 cycles of chemotherapy, and these are some of the studies that are associated with it, with just a small amount of radiation, and then you have those patients who do have favorable or no risk factors, no bulky disease, and can have minimal chemotherapy, 3 to 4 cycles of chemotherapy in total, followed by restaging, imaging, and radiation. And we'll talk about all these studies and how they've helped incorporate. And you see here, sometimes there is a preference to treat with combined modality therapy. And the bottom line will be within your group and your in your multidisciplinary setting, or whether you're in an academic or community setting, is the planned intent of treatment. And really, you should have a preference in your group to treat with combined modality therapy or to treat with a chemotherapy alone approach. And I would suggest, and the data would suggest, that this approach may be suboptimal for certain group of patients, and we'll help define that. So sort of starting in a more historical fashion and then moving to more modern studies, I think we should pay attention to the German Hodgkin study group HD10. And for those who have trouble remembering which study is which, the German Hodgkin study group is always HD, the EORTC is always with an H, HU or HF based on favorable, unfavorable. But HD10 was our sort of landmark study in the New England Journal of Medicine about 10 years ago, the first publication that showed that it had 4 arms of the study. There was no PET imaging, but patients had, as defined by the German Hodgkin study group, without risk factors, early stage disease, had either 4 cycles or 2 cycles of chemotherapy and 20 gray or 30 gray of involved field radiation. We'll go over the fields and how that worked out. But the bottom line was with at that time short follow-up of about just 5 years, there was equivalence. There's non-inferiority of the 2 plus 20 versus the 4 plus 30 gray. So this became the standard of care in the German Hodgkin study group and many other groups to follow. But as I mentioned, please do remember the risk stratification factors. If these patients, although they are a bit more conservative and more generous as far as the definition of the German Hodgkin study group, of the definition of their nodal regions, please do make sure that when you try to treat a patient with 2 cycles of chemotherapy and 20 gray radiation, that you follow this and they do meet the criteria of this study. And so important, one of the criticisms that 5-year follow-up was not enough. And we have a 10-year update that was published just a couple of years ago, and found that there was continued to be non-inferior. There was no significant difference in outcome between 2 and 20 versus 4 and 30. So 2 and 20, 2 cycles of ABVD and 20 gray of radiation is the standard of care for patients who have early stage favorable classical Hodgkin lymphoma that meet the criteria for the German Hodgkin study group. Now remember, this was not PET staged, right? So we had a sort of a modernized version of HD10, the German Hodgkin study group HD16. So you'll see here, and very, very impressive across the entire world. And I don't know if anyone from this call is from Germany or enrolled patients from there, but very impressive study group. They enroll thousands and thousands of patients over a very short period of time throughout their consortium of hospitals. And here you see 1,100 plus patients in just a 6-7 year time span. And these are patients with early stage disease. It's really replicated the HD10 study in a more modernized format, and took patients with PET, interim PET after 2 cycles, and randomized to receive either radiation or no further therapy. And here you see the experimental arm. This was a standard arm from HD10. And the primary objective was, can we omit radiation without losing tumor control in these patients using PET? And so this was presented last year at the as a clinical trial oral session at ASTRO. You can see here the HD16, the primary endpoint progression-free survival, showed that there was non-inferiority to patients. I'm sorry, the non-inferiority margin was not excluded, meaning that the chemotherapy alone approach, or 2 cycles of ABVD alone, was inferior to 2 cycles of chemotherapy and radiation to 20 gray, with a difference of about 7% between the 2 arms. This was the final analysis for 5-year progression-free survival in favor of the combined modality therapy approach for patients with favorable Hodgkin lymphoma and early stage disease. And you see here overall survival was about the same because, as you know, and we can appreciate that salvage for the small number of relapses is actually quite effective. So they sort of dissected, if you look at, there's a nice study that was published in addition to, I'm sorry, that was presented in addition to this very important landmark HD16 study. It was a subset analysis of patients, what happened with the sort of those patients who are PET negative. So despite a PET negative, and this is the arm with no radiation, you had actually quite a bit of early relapses and late relapses. So that's where the compromise of the progression-free survival happened. And if they were treated, then it was all sort of in what would have been the field, or many, there are about 10% or so, it would have been in the field of radiation. So, you know, that becomes an issue when you could have easily treated a patient with 20 gray of radiation therapy. And then the secondary endpoint was, does a PET scan after 2 cycles represent, does a positive PET scan, does it actually represent a risk factor of progression-free survival? This has been demonstrated in advanced Hodgkin lymphoma. In fact, that's where the Deauville score validation was performed in the advanced Hodgkin lymphoma patient, but this was a nice validation in the early stage patients, in patients treated with standard of care. And you see here patients who have a Deauville score of 4 or 4 have a much worse survival than those who have 1, 2, or 3. And so this is why it's still very, very important, despite the intent of treatment and the treatment protocol, that an interim PET CT scan after 2 cycles is a very has prognostic implications. And those who are treated with radiation, we see here those who are PET negative and PET positive. The patients who are PET negative and treated with radiation really have the best outcomes, and this is from the combined modality therapy arm. So just to sort of summarize a very important study, we now sort of we look at HD16, and we used to always refer to HD10, but now HD16 has relevance in our practice because of the modernization of the treatment and the interim imaging. That radiation cannot be safely omitted without a clinically relevant loss of tumor control. And PET after 2 cycles has significantly poor progression-free survival in patients who are treated without radiation. And really that positive score of 4, Deauville score of 4 after 2 cycles, has really a much worse outcome. There are some subset analysis that will be performed of looking at more of the localization of these progressions in PET negative patients. And you see there was a nice abstract from last year's ASTRO, and there will be more data coming even this upcoming ASTRO. I hope you do all attend remotely, obviously, but there really are there any more in-field relapses after omitting the radiotherapy? And we do find that even after PET negativity and no radiation, you see here PET negative patients in potential in-field recurrences in an area that would have been a radiation field were much higher. So, you know, we will. The next step is really, I believe you'll see some data on perhaps looking, this, remember, was involved field radiation, but what about if we change that definition to more standard involved site? Were those relapses really outside of our involved site field or within that as well? So let's kind of move along, and I think we'll take questions towards the end. I know questions will come up, and you know, whether they're about the data or the practice and how these patients should be approached, but I think we'll save them for the end. Sort of move to the unfavorable risk category of based on German Hodgkin study group studies. And here is an example of HD11 where the thought was to escalate chemotherapy and perhaps even reduce the radiation therapy. And it really wasn't possible if patients received ABVD chemotherapy. And that was based on this HD11 study where freedom from treatment failure was much higher in patients treated with ABVD in 20 gray, you see here, versus the standard of care here. Now, in your practice, if BIACOP chemotherapy is used, I know in Europe is a widely used regimen, especially the hybrid ABVD and BIACOP regimen for unfavorable risk patients. However, that hasn't caught on as much in the United States, largely for concern over hematologic toxicity. But if that is used, then 20 gray radiation for unfavorable patients may be reasonable based on HD11, and we'll see some more data on that in some studies we'll discuss later. So here we do have HD14, which is it's still a pre-PET era study, and you see here for unfavorable patients this hybrid version of BIACOP and ABVD, and this has become sort of the standard for the German Hodgkin study group. And you see here the reason for that has been the at the cost of hematologic toxicity, some improved progression-free survival, almost 10%, about 7% in patients who have this hybrid regimen. So that sort of became the backbone of the German Hodgkin study group, unfavorable risk patients. And that you see here, and this is really very sort of groundbreaking data that I'll share with you. Many of you may have seen this in the European Hematologic Association meeting that was also virtual. The HD17, so they took the modern they took HD14 and sort of modernized it by adding an interim PET. Remember, interim PET after 2 cycles has after 4 cycles was done here, has a prognostic and perhaps predictive elements. And so here they completed recruitment, once again, a very impressive 5 to 6 year time frame, about 1,100 patients enrolled, almost exactly 1,100 patients, very few dropouts, almost everyone was eligible. It was a non-inferiority strategy to look at progression-free survival after 4 cycles of chemotherapy, this hybrid version. And those patients who are PET negative were randomized to combined modality therapy or 30 gray of radiation versus no radiation, no further therapy. And interesting for radiation oncologists, those who are PET positive received either 30 gray of involved field or involved node radiation. So there's a nice study that we don't have this data yet, but I imagine this will be available as well. So these are some early results from this year, this summer, that from June in the European Hematologic Association. So as we mentioned, this was really to look at progression-free survival and to look at this perhaps non-inferiority design of a PET after 4 cycle guided strategy. The median follow-up as of now is almost 4 years, and we found in the standard combined modality therapy arm, the progression, remember, this is unfavorable risk patients. I just want to remind everyone this is with risk factors, so unfavorable early stage classical Hodgkin lymphoma. In this group, the progression-free survival is about 97% versus 95% in the PET-guided treatment group, meaning chemotherapy alone. So that 5-year progression-free survival was statistically identical, excluding lower margin of about 8%. So about 2% difference, 2.2% difference, not statistically different between radiotherapy and chemotherapy alone approach. So you see here about a 2% difference in the 5-year progression-free survival for PET positive patients, 94% versus 97%, and then for the PET negative patients. So this actually confirmed the PET as a significant risk factor, meaning if you're PET positive after 4 cycles, you have a increased hazard ratio of death or progression-free survival with this disease. And especially when the cutoff was Deauville score of 4, as we saw in the previous studies, the progression-free survival rates were significantly different, and that has some prognostic value. So that was a secondary endpoint. Just want to keep in mind that for patients who have, this is based on the primary endpoint of a combined modality therapy versus chemotherapy alone approach, about a 2% benefit in the unfavorable risk classical Hodgkin lymphoma patients where omission of consolidation radiotherapy was without any relevant loss of efficacy. So keep this in mind when you approach these patients with unfavorable classical early stage Hodgkin lymphoma. So we'll see this as a trend. And so I do want to touch on this study because it's another modern PET era study, the H10. So EORTC did a nice study with a favorable cohort and an unfavorable cohort. And this is really how our role of radiotherapy has evolved in the last 10 or 5 to 10 years is really because of these studies. And we've modernized it. We're using PET scan after 2 cycles. And you see here the randomization of patients getting, now remember they use involved node radiation in EORTC, and we'll talk about that. And I think that has a real large applicability for patients in your practice. If you do administer the chemotherapy, then involved node radiation is something you should think about if you haven't already. And then there was, in these favorable and unfavorable cohorts, there was escalation of chemotherapy in the combined modality approach with PET positive, and then those who were PET negative had chemotherapy alone, either 4 or 6 total cycles based on risk factors. And then these were compared to patients who had radiation. So you see here, after 1 year, this is really important, and all of you probably already know this, but a few years ago, the planned interim futility analysis after median follow-up of about 1 year was performed in the H10 study. Patients with early PET negative disease, remember after 2 cycles of chemotherapy, found that the chemotherapy alone approach had excess events of relapses, and thus at this planned interim futility analysis could not demonstrate non-inferiority in the experimental arm at a statistically significant point. So in June, about 10 years ago, in June 2010, all investigators were notified to stop. So the PET negative arm, the PET negative and no radiation arm were forced to stop. In fact, patients who were treated on this arm, if they're treated within 6 weeks, they were called back to receive radiation because it became the standard of care. So when you analyze this further, if you look at the median follow-up of about 5 years, published a couple of years ago in the JCO, if you look at early PET negative patients, these are favorable risk patients, so they're favorable risk after 2 cycles of chemotherapy, had PET negative. There was a significant improvement in patients who had combined modality therapy approach versus chemotherapy alone approach, over 10% benefit in median follow-up of about 5 years. So this showed the benefit of radiation in patients with favorable disease. So keep that in mind, and then we'll sort of circle back to where this sort of makes sense. Another study that we should keep in mind is another modern PET era study performed by the UK NCRI Rapid group. These are patients, they follow their own favorable and unfavorable risk factors, but largely had 2/3 of these patients were favorable by other criteria when applied to this patient cohort. About 600 patients were enrolled, and they were all early stage disease. Like I said, 2/3 were about favorable. They had 3 cycles of chemotherapy. If they're PET positive, they had what was the standard of care, 4th cycle, then radiation therapy. If they're PET negative, then they were randomized, and PET negativity was Deauville score 1 to 2. It's a little bit different definition on this study. Randomized to radiation versus no further therapy. And this is where the bulk of the data and practice-changing data comes from. This was published in the New England Journal of Medicine just about 5 years ago. So there's after 3 cycles, as we mentioned, there were PET negative. Interim PET was performed, and if you see here, about 2/3 of these patients were PET negative. This is very different than maybe what we see in our clinical practices, and we should think about that when we approach these patients and discuss these patients in a multidisciplinary setting, because PET negativity, these were quote unquote centrally reviewed, and there's a nice editorial about how these were centrally reviewed, and perhaps the nuclear medicine radiologist was sitting not too far from the other one, and perhaps PET positivity would have brought that patient more therapy, and knowing that up front doesn't truly blind these reviewers. But regardless, these were the findings of the study, and there were some that were truly not randomized, and we'll talk about that in a minute. But in the radiation arm, there were about 26 patients that actually did not receive radiation, either for patient or provider of choice. There's some that died before radiation, and this kind of reminds you of an old study, HD6, where the NTIC, where there were some issues with the patients who were actually assigned to radiation and did not receive it. But nevertheless, the findings published in New England Journal of Medicine using the intention to treat analysis, progression-free survival in the randomized PET-negative patients was found to be not statistically different and in favor of radiation, but not statistically different. And it was just under 7% difference in progression-free survival at 3 years. So as you remember, 26 of these patients didn't actually receive radiation for various reasons. So that was the intention to treat analysis. If we look at what was actually done and as treated analysis almost of the 400 patients, now you see about a 7% difference in favor of combined modality therapy at 3 years compared to the chemotherapy alone approach. But this is sort of unfortunately embedded in the New England Journal of Medicine article. But I really suggest you to read further into the details, and this is what the actual findings are in the as-treated analysis in favor of combined modality therapy approach. And of course, as you've seen across all the other studies, overall survival is about the same in all cohorts. So to summarize this study, a very conservative definition, about 3/4 of the patient were PET negative, and as I mentioned, it rarely happens in routine clinical practice. The most common score I get is a 3, and that's a tough one to deal with. But as you saw, as a radiation oncologist, we're biased to think and look for perhaps a role for radiation in favor for these patients. And in the per protocol as-treated analysis, we do find that, but technically in the intention to treat analysis, that was not the case. But the PET scan does of course help us identify those patients to reduce risk of relapse. So in the last 20 or 30 minutes, if you were not paying attention, this is the slide to pay attention, where I've sort of tried to summarize all of this and take a snapshot of this or maybe a copy of this as you tried to put this all in perspective. Here's the study we just talked about, the UK Rapid, where we found an absolute benefit of about 6%, 6 to 7% if you stretch it. The H10, the favorable cohort, was about 11 to 12% benefit. HD16, about a 7% benefit. Now, one thing I do want to keep in mind is unfavorable cohort. And this is where the questions really become gray, and the clear for radiation becomes a little bit grayer. The role for local therapy, you see unfavorable cohort in the H10 study was about 2.5%. In the HD17 study, about 1,100 patients here dedicated for unfavorable risk patients, about 2.2%. So when our absolute benefit and difference in progression-free survival with local therapy starts to go to 2%, and we may want to question the role of radiation in the unfavorable cohort, but certainly in the favorable cohort of patients, there's a clear benefit to combined modality therapy. So this is sort of the takeaway table of all of these studies. And there's some, because all of these studies aren't powered for overall survival and things. So, we do see progression-free survival, but if you kind of take all of these studies, the HD16, the H10, the RAPID study, and then you look at secondary malignancies and grade 5 toxicities that can happen with excess chemotherapy and radiation, you do still see a progression-free survival benefit, but then the overall survival starts to weigh against the secondary toxicities, and perhaps there's no difference in overall survival, which is validated in multiple meta-analyses. So I do want to touch on some of the, how are we doing with time? Are we okay with time? It's about 30 minutes.
Yeah, we are okay.
All right. I apologize for going a little bit fast. I just wanted to get at least you access to all these slides, and make sure you have enough reference for every you guys all have this. So I'm not going to really dwell on advanced Hodgkin lymphoma for too long, but there's some commonalities in our role for advanced Hodgkin lymphoma. Remember, some of these are before the PET era. That's why I tried to. This is a nice. This is published in Advances of Radiation Oncology. It's published this year. It's a nice compilation of some of the. It's an overview review article on this and studies that incorporated radiation. So not all have purposely incorporated radiation, and certainly these studies were not investigating the role of radiation. It was rather the role of augmented chemotherapy regimens, or perhaps even newer agents. But if you see here's the EORTC study, the UK study, there's and then the ECOG study. They didn't use PET scans, but you see radiation dose can vary. However, some studies, all original sites are included, and of course to a lower dose. But most of them were really, the radiation fields were just to initially bulky disease, and using 10 centimeters of outside the chest, or about a third of the chest. And then residual CT masses, we look at, in the pediatric Hodgkin lymphoma studies, we've looked at 2.5 centimeters, similar to other studies of residual CT masses, and there may be some value to that. But we really should be getting PET scans now. So if the access to PET scans is not great, then perhaps we can look at some of these older studies and look at CT dimensions. But the standard of care should be PET in this era. So if you look at this initially bulky disease and the persistent post-chemotherapy PET scans over PET mass over 2.5 centimeters that are persistently PET avid, that may be a role for radiation. And those are going to be usually at the areas of bulky disease, as would be expected. There's one study that used 5 centimeters, I'm sorry, 2 studies that used 5 centimeters as bulky disease as a cutoff, and it kind of goes towards that non-Hodgkin lymphoma, closer to that, but about 30 gray is what you need. Patients who have, and there's a very good, excellent ILROC guidelines for helping you develop the volumes and doses for patients who have this criteria. And this is from the same nice article published this year. How do you look at advanced patients? This is really kind of staying back with our early stage disease, but what about the stage 3 and 4? Treat at advanced stage, you get chemotherapy, and if they don't have complete response, really, 36 to 45 gray comes from depends on the level of response. If it's a Deauville 4, you probably want to 4 or 5. You want to go higher for residual disease. And then if there's complete response, these are the things that we really need to consider. Is there a large residual CT mass over 2.5 centimeter? What was the interim PET status? What were your potential radiation fields? Remember, including a lot of marrow in patients who have 6 to 8 cycles of chemotherapy will be difficult. And then in the worst case scenario, if the patient has a relapse, what are salvage options? Is transplant an option at your center? If it's not an option for the patients, then you want to really maximize upfront therapy, and perhaps radiation needs to be more sought after. So here's some summaries. I sort of made up a very favorable, but just think about HD10 and HD16, how that's helped us do 2 cycles and 20 gray of radiation. Sorry, 2 gray, well, I don't think that's going to happen anytime soon, but 2 gray is okay for other things, not for Hodgkin lymphoma, but unless MD Anderson or Stanford come out with some studies soon. But 2 cycles and 20 gray of involved site radiation, or 3 and 30, those are all very reasonable approaches using combined modality therapy. Remember, one of the themes that we will have is that your multidisciplinary group should have a planned intent of treatment at the time of diagnosis, and I would encourage every radiation oncologist to see these patients upfront and help develop this plan. Seeing a patient, if you're delivering the chemotherapy, that's even better. You've already seen the patient, and I would really encourage at that point to what we'll discuss involve node radiation if you are seeing this patient. So, and then chemotherapy alone approach. Remember, for the favorable risk patients, there is an expected lower progression-free survival, and if you said 7 to 10%, that would be a very reasonable quoted number. But for the unfavorable patients, remember HD17, the H10 U showed that it was more like 2 to 3%. So we should keep that in mind also. Remember, this is the unfavorable patients. And then the advanced patients, as we mentioned, adding involved site radiation, 30, bulky disease, incomplete response. Remember, using PET scans. So just a very, very brief note on relapse refractory Hodgkin lymphoma. This is a great article to use when looking at patients who perhaps relapse and you can't capture for radiation previously. And usually that would be the case if you have not irradiated these patients. Unirradiated patients have a higher risk of relapsing, as you know from progression-free survival. And so when they relapse, what do we do? These guidelines are really helpful to help define your volumes, your doses, how generous, how less generous your volume should be, and also goes through different scenarios that you can try to fit your patient into as you approach them in the clinic. And so, just one one study on this. One compilation of various studies. These are small studies dating back and more modern. But you see here that the patterns of relapse after stem cell transplant and unradiated relapse refractory are really in initially bulky sites, however you define them, in the previous sites, and all really local. And so when they're unirradiated, this is unirradiated groups, the old and new sites, the initially involved sites are the highest risk of relapse, and especially if they're bulky. So maximize all therapy up front if possible and if indicated. So I'll spend the next, I think we have 20 minutes or so. I'll try to go a little bit slower on this because it has more implications with the radiation oncology, especially trainees or junior practitioners who want to look more about the modern radiation techniques. And they're very important guidelines. This is in 2017, so about 3 years ago. The most downloaded articles we noticed in the Red Journal, the 3 out of the top 5 downloaded articles were the ILROG guidelines. And what that told us as a group of in ILROG is that this was really needed. This was needed in our community. It was needed for trainees and practitioners. And so I would refer you to them, but just keep in mind, these are now getting outdated, but this was the initial attempt, and there are more efforts ongoing within our ILROG group actively as we speak to put out more modernized treatment guidelines. So just keep your ears up for that, and we should, you should have those in hand if you're treating this. So this is really evolved, right? So those on the line have been practicing for many years. You may remember this. I do remember this. Regional nodal radiation when I was a trainee. Involved field radiation was also done, and the doses of radiation have come down a lot. And 2019, 2020, this is what we do for a patient who had a small node would get total nodal, then involved field. You guys remember the mantle fields and perhaps involved field. Now, really, there's a significant reduction in volume, and that should and has led to a significant reduction in quality of life as secondary effects of radiation, besides the modality of radiation. So the volume for first, and then the dose has come down to 20 to 30 gray. To involve site is really the standard of care worldwide as of today. So this is towards the tail end of my training. The involved field was back. This was 2002. This was great, because it told us, it gave us some guidance on how to treat. But remember, this is gone. This involved field is gone. This is 2002. This is not how we should be treating. Now, these fields with disease here should not include all of this excess tissue based on bony landmarks. We have now these strategies to improve the therapeutic ratio, and that's what we try to strive for in every tumor site we treat. So the involved field is based on the 2D anatomy and included entire lymph node region, uninvolved region. Involved site is what we do now, and this is really to account for limitations we have when we see the patient for radiation. Disease site specifics includes the original extent of disease and potential areas of spread, not uninvolved areas. And then involved node is something that is just the original extent of disease, as you may know, with a small margin. And we'll kind of review these. And this is in red what I practice every day in our clinic. The question arises, and we should always question just because we can do it, why should we? This is a nice study that was published a few years ago, and looking at childhood cancer survivors. It was a very small study, but it looked at the survivors and looking at the transition from involved site radiation, and does it make a difference in late toxicity? And these are really small numbers, so these error bars are pretty large. But if you look at the doses, just the trend of the doses you see between the CCSG and the COG, you see these doses have come down. Our breast dose is reduced from 18 gray to 4 gray of the mean breast dose. That's a big difference. This is regardless of even modalities, just the volume, the radiation volume of exposed normal tissue. And you see all of these. The heart, you see the thyroid going down. The heart doses have gone down. They all have gone down as significantly. So I would just to start with the involved node radiation. This, sometimes trainees or folks get confused between involved node, involved site. Am I putting margin? Am I not putting margin? It all depends on when you see the patient, the type of imaging you had at your leisure, and the treatment position or not. And so the involved node radiation is a technique it's actually not a new concept. It's almost 15 years old, over 15 years old. This is done in the EORTC, the H10 study. This was the concept. And yeah, as I mentioned, it's not a new concept. So if you're seeing this patient at the start, before chemotherapy, and you are diagnosing this patient and have a PET scan in the treatment position, so pre-chemo PET scan in the treatment position, and you're able to do this with the immobilization device and in treatment position, you can practice involved node radiation as long as you have good fusion with post-chemotherapy planning, and et cetera. So following this practice is reasonable only if you see this patient in treatment. So in our practice, my hematology oncology colleagues deliver the chemotherapy, and I often do not see these patients, or at least cannot simulate these patients before they're ready for radiation or after chemotherapy is already started. So we do make the treatment decisions before, but I often don't see them to physically simulate the patient before chemotherapy started. So I unfortunately cannot practice involved node radiation, but I do involve site radiation. So there are studies, the British Columbia group has published some of this in non-Hodgkin lymphoma. This is a nice study for Hodgkin lymphoma. You have to always, once again, question, well, are our fields too small? Can we limit the size of the field without compromising tumor control? And this study went back and sort of looked at all of their patients using a field that was less than 5 centimeters, which sort of was would have been the size of involved node radiation. Look at extended fields and involved fields. And we found that none of the relapses that occurred, there were 12 relapses in the study, over 300 patients, so a small number as expected, and none of them were within the involved node or just outside the involved node field. And I'm sorry, none were just outside the involved node field and in the extended or involved field size. So what that meant was all of them there were no marginal recurrences from the involved node design. So all of them were well inside the field of radiation, if at all within the field of radiation. So this should be a safe approach. There's other studies that also validate that as well. And then if you look at the German Hodgkin study group HD16, we'll have more data in a randomized fashion if involved node radiation is just as good and does not compromise outcome as involved field. So our standard of care has been involved site radiation, and the idea from this, at least from the ILROG consensus and our efforts from ILROG, has been to use a similar approach as our counterparts in the solid tumor world. We want to base our conventions on the ICRU report 82, so using target volumes, GTV, CTV, ITV in some instances, and PTV, and you want to base it on modern 3D imaging, functional imaging, which may or may not be, once again, performed in the treatment position. So these techniques, and sort of, I would reference the guidelines for your techniques, but what I always tell providers is this is your most important target volume, the involved site CTV. So what you do, and I'll show you a couple of examples, is you take the pre-chemotherapy PET scan, you fuse it to your planning CT scan, and some places, departments use deformal registration, some use rigid, don't have access to deformal registration. Either's okay. Just be aware when you do deformal registration, there can be some stretching of the imaging and anatomy, so just keep that in mind. But I often even use rigid imaging and just beware of the anatomic boundaries. You want to expand this pre-chemotherapy disease volume with about 1 to 1.5 centimeters margin craniocaudally, this is the most important aspect, in the direction of potential lymphatic spread. So you want to expand it in that way. Now, you don't necessarily need to expand it in the transverse dimension. You don't need to expand it into muscle, bone, plane, because those are not areas that, unless they were previously involved, you really don't want to extend it into those uninvolved areas. And then the PTV is sort of based on your immobilization device, your setup uncertainty, and accuracy. And of course, in the mediastinum, four-dimensional planning, and I'll go over some breath hold techniques that I use in my practice that you should hopefully feel comfortable using. So here's some examples. If you see here, there's a patient with mediastinal lymphoma up on the top. The pre-chemotherapy volume is highlighted in yellow. And so this is now conformed to the current normal anatomy. So if the tumor here was extending into the lung space and it does not involve it, you should now conform to the normal anatomy. And then there's expansion. The red is the involved site CTV expansion in the direction of potential lymphatic spread. So this is a great example how 1.5 centimeter expansion brings you to the superior mediastinum. You avoid some dose to the thyroid as opposed to our previous large involved fields. And then here you see an expansion here, but you don't see this expansion because there's no area of potential lymphatic spread, because that is the heart border. And we'll talk about that too. But that is important to note because this is now your involved site CTV. So similarly in the neck, you see here the previous pre-chemotherapy PET scan is fused. The post-chemotherapy GTV is yellow. Pre-chemotherapy nodal area is in yellow, conform to the normal anatomy currently. So if the tumor is bulging out, it's no longer. If it's not involving the muscle, you don't need to include it. And then the CTV now expands in the area of potential lymphatic spread. So that's nodal region and only in the area of potential lymphatic spread. Similarly, you see in the groin here, of a patient with inguinal lymphoma, similarly expanded in the area of potential lymphatic spread. And here you see the periodic lymphoma patient chain here, and you expand it so you don't go into the kidney, the bowel, and the other normal tissues, vertebral body. It stays out of that space. So you see here the involved site CTV expansion is pretty straightforward. Even if this pre-chemotherapy volume was going into, or not into, but abutting and pushing bowel, now it has resorbed into this area. So involved site CTV will include just the areas of potential lymphatic spread. This should be one slide. As a practicing rate, if you're practicing table here, because this is what this actually I've taken from the ILROC guidelines for proton therapy, but this has a relevance to all patients getting particularly mediastinal radiation with lymphoma. One thing we have to remember is if you treat lung cancer, lung cancer, that's a diseased lung, you may say that a V20 of your lung is okay. V20, 20 gray, a mean dose is okay, or V20 maybe 35 or 40% is okay in patients who have lung cancer, but it may not be as okay when you're only treating to 20 or 30 or 36 gray in patients who have this. For example, in lung cancer, V30 of 30 gray to the heart would be very reasonable when going to 60 gray with chemotherapy and radiation. That would be unacceptable in a patient with Hodgkin lymphoma treating to 30 gray. So keep this in mind. And then one thing that has been pretty well validated, and it was just largely modeling studies previously, but now we have good, strong, robust clinical information that shows about 1 cycle of anthracycline equals 5 gray of mean dose to the heart. And there's a nice reference here for your use. So just think about that every time you discuss a patient in a multidisciplinary setting when the options are either 2 more cycles of chemotherapy, usually anthracycline-based chemotherapy. Now this applies to Hodgkin and non-Hodgkin lymphoma versus just, and that would be equivalent to another 10 gray to the heart, which would have significant adverse outcome. And just overall, remember, this is not a solid malignancy. And these, keep this in mind, the thyroid, the lung, breast dose, we try to keep as low as possible for, it's obviously age dependent, and then the heart dose. And so cardiac toxicity, as we know, is very real. This is the same toxicity. It's because it's the same organ that we've treated in breast cancer. So it should have the same excess relative risk of coronary heart disease per gray, about 7%. We've seen this in all of the studies in breast cancer, and now we've seen it in all of the studies with Hodgkin lymphoma. So this is real. One thing that we'll talk about in follow-up is remind your young adult patients, do not pick up smoking, because that's going to increase this at least tenfold. So actually, Dr. Mondell is really an expert at this, and he can share with you some of his tricks and tips. But if you want to really get into what is the cardiac exposure after radiation, well, we don't know until we contour it, right? Those are the philosophies of radiation. If we don't contour it, it never happened. And so we have come to a practicing point in at least in mediastinal lymphoma radiation oncologists that we routinely do contour the right coronary, and all the coronaries, especially if you can see it. We don't need to get sometimes a dedicated coronary CT. You can if a patient has it on file, but you can usually see it in a good contrast CT simulation. If you do the thin cuts, you can see these very well. And here, and this is a nice reference for you to look at, the substructures of the heart, left ventricle, obviously very important. And then important, and as you practice other thoracic malignancies, you'll remember, where does the heart start? Just inferior to the left pulmonary artery. So just remember the superior border of the heart, and that'll help you quite a bit, because sometimes we have structures and targets that drape directly over the heart. This is another nice study published a couple of years ago about looking at cardiac avoidance structures. We do routinely, as I mentioned, and this is where obviously where the heart starts, and this is sort of what ends up looking like when you contour it out. And the biggest question I get is, well, what about the dose? What should I make my dose? Well, I don't know, and we don't know what the dose should be. We do know that at least as a surrogate, the mean heart dose should be less than 5 gray. But what we do recommend is if you're using very sophisticated techniques, IMRT, proton therapy, they can have, really those modulated beams can have heterogeneity, and those hotspots sitting on the valve and the coronaries can become a problem for patients who are young and otherwise healthy. So and have been exposed to anthracycline chemotherapy. So just keep those in mind, and stay tuned. I think in the next 5+ years we will have significant constraints for all of these, and we should strive to make sure they're as low as reasonably possible. So, and then pulmonary toxicity. I think this is a pretty interesting study, and that's why I included it in this slide, in this talk. We have some pretty good data on mean lung dose, V5s and 13 gray or 10 gray mean lung dose. I think 10 gray is what I shoot for, or V5 less than 55, because those are 10 and 5 gray is very relevant to heme toxicity. There's a nice study that was presented last year at ASTRO, looking at a little bit of a different indicator, not just a dosimetric parameter. So this is from MD Anderson. They implemented these mean lung doses and V5s of their lung. They found that after that, the radiation pneumonitis rates were significantly lower. However, this is a very heterogeneous group of patients. A lot of them had chemotherapy up front, and some were, they were salvage chemotherapy. So they're heavily pre-treated is the bottom line. What they found was that those patients who had higher neutrophil lymphocyte ratios had a protection against radiation pneumonitis even after incorporating these metrics. So, I've started to at least look at that. This generates some hypotheses that perhaps need to be tested and evaluated in larger cohorts, but perhaps there's an inflammatory response that's already active that could compete with the immune cells that are responsible for the radiation toxicity causing pneumonitis. But there's some idea that perhaps there's some host factors that we can look at besides just the treatment-related factors that we've developed. And then it's something that we should always keep in mind. This is, we have data from the childhood cancer survivor study cohorts, particularly higher doses of and higher cumulative doses and lifetime doses of alkylating agents and platinum agents and anthracyclines. Cancer rates go up, secondary rates go up. Large fields of radiation do that, but also lots of chemotherapy. So when we can reduce chemotherapy, reduce radiation, I think we have the best outcomes. These are historical fields. I do hope I've convinced you, if you are using APPA fields, you're not using those anymore. If you're not using them, that's great, because we should try to evolve to the modern practice. IMRT, this is kind of, we look at IMRT where sprays dose everywhere, but then you can use this butterfly IMRT technique. This has been spearheaded by the MD Anderson group, but it's well tolerated at extremely low doses of radiation elsewhere. So I think it's important to note that there are techniques. You don't need fancy, expensive equipment. One of the approaches I like the most is breath hold. It is probably the most cost-effective method that I found to reduce dose to the heart and lungs, and those that practice breast cancer as well can really appreciate when you move the heart away from the chest wall in your breast fields. But what happens in the mediastinal target, as you know, in a deep inspiratory breath hold, the mediastinum or the target narrows, the heart drops caudally, thus out of the radiation field. So you see here in the normal thing and a deep inspiratory breath hold technique, there's a significant difference in lung exposure and heart exposure to our radiation field. Now, if we combine this with modulated beams, we have really an excellent option. What I do in my practice, I have the luxury. There's a lot of different ways to do breath hold. There's active breathing control, there's passive breathing control, there's external monitoring, surface monitoring. I use an optical surface monitoring system known as OSMS, Vision RT system. It just happens that's what my practice has, and that we've used that for breast cancer and validated our outcomes and experience. I use that on our proton beam. So you can imagine our doses to the heart and lung, even with tumors that are draping right over the lung, right over the heart border, have very low doses. This is a nice guideline. I just encourage folks to read it. If you have access to this, it's great. If you don't, it's okay. But how do we best define those patients who may benefit from proton therapy? There's perhaps not everyone, but if you have patients who have superior anterior mediastinal disease and is draping over the heart, the target volume, you can spare the patient all of that excess risk of radiation. If you want to completely omit radiation breast dose and you have disease, you're using a posterior beam, there's no exit to the breast dose, but there's nothing we do has no harm, and there's always going to be an entrance dose. And I think this is something that's we're working with, and particularly when you have heavily pretreated patients, you really want to minimize radiation-related toxicities to our patients. So, after they're treated, I just have left this in here for your reference. This is from the NCCN guidelines, which is very, very comprehensive with how to follow these patients. One thing I found, and this follows the Lugano classification recommendations, surveillance PET scans should not be done routinely due to the risk of false positives. I cannot tell you how many false positives I have seen in the last decade just from overzealous patients or providers. After one negative PET scan, an early stage Hodgkin lymphoma with good, robust combined modality therapy, management decisions shouldn't really be based on PET scans alone later. And then, just be aware of the normal blood abnormalities that can happen after radiation exposure, like any other case. And also, screening for other malignancies and other secondary effects is important. So I think I've just finished with just about a minute over time. I wanted to these are just summaries, modern imaging, significant volume reduction. We have really evolved in radiation therapy, but we've evolved in the treatment management of Hodgkin lymphoma, and radiation is just a component of it. We use solid tumor principles. Modern techniques can be helpful. All right. So thank you for your attention, and I think I went over for a couple of minutes, but.
That's wonderful, Dr. Parikh. And
thank you.
As it has always been, you were really awesome in this presentation. And you actually completed the entire topic related to Hodgkin. So starting from the workup and then the treatment, the follow-up, everything, and including the planning part. That was really excellent.
Nice.
Uh,
Thank
there
you.
are a couple of questions. I think if we want to take all the questions, it will take another 15-20 minutes. So
Sure.
all right, that's great. So the first one, how would the HD German studies compare to the UK studies in 90s with 2 to 4 cycles of chemo and then reduced RT dose of 20 and 30 gray, depending on response, although it was not used for response evaluation?
So question is, how does the German Hodgkin study group, sort of the modern studies, compare to the UK rapid study? Is that the sort of? So, you know, it's a little bit of apples and oranges, but when you look at the UK rapid study, you can try, because they had their own definition of favorable risk, of no risk factors or favorable risk. And if you look at about 68% of those patients met the criteria for German Hodgkin study group. And about 2/3 of those patients met the criteria for the EORTC risk factor group. So the majority of those patients were early stage without risk factors and favorable early stage patients. So how do you reconcile 3 cycles versus 2 cycles versus 4 cycles? So I think that's where the NCCN does allow for some leeway. If you commit the patient to 2 cycles of chemotherapy and PET assessment and they're negative, and they met the criteria for the German Hodgkin study group, you can do 20 gray of radiation. That is a very reasonable approach. If the patient gets 3 cycles of chemotherapy and meets the criteria for the EORTC, but not the German Hodgkin study group, they should get 30 gray. Now, if they have 3 cycles of ABVD and they met the criteria for German Hodgkin study group HD10 or HD16, you can still do 20 gray of radiation because they essentially receive 1 additional cycle of chemotherapy unnecessarily.
All right. The next question is, yeah, that's nice. That's nice. The next question is, can you please share some perspective on NLPHL, the role of radiation alone in stage 1, 2, and role in stage 3, 4? Any difference in doses would you use, and what is your center's practice for CD20 positive NLPHL, or ABVD or RCHOP?
So that's a great question, and that comes up, you know, so if you have to sort of break it down, I sort of left it just because of interest of time. I left it off of the, you know, just focus on the classical histologies, but you know, the nodular lymphocyte predominant Hodgkin lymphoma, you know, we've published quite a few studies on using radiation alone. And if you look back at the German Hodgkin study group HD10, there were some LP Hodgkin patients treated there. And if you look back at the Children's Oncology group early stage studies, there were also LP Hodgkin Hodgkin lymphoma patients on. They do extremely well. So stage 1, non-bulky disease, stage 1A, no B symptoms. So you have to have those 3 factors, and the NCCN does reflect this, is radiation therapy alone is a very reasonable approach. 30 gray of radiation using involved site criteria based on the ILROG guidelines for LP Hodgkin is the standard of care. Now, if there are B symptoms, the patient has signs of, so stage 1 non-bulky or stage 1 bulky with B symptoms, so and or B symptoms and or bulky, now the option is rituximab-based treatment. Some patients in our center have received an R-CHOP-based regimen, which is probably too much. If you look at some of the other studies on LP Hodgkin, dedicated for LP Hodgkin, you find that adding rituximab-based therapy to localized, even bulky 1B patients or 2B patients, localized contiguous sites, there's no difference in outcome. So what I would argue is that radiation alone, if it's bulky, 36 gray would be reasonable. Beyond that is not necessary. And 30 to all of the sites that are involved, and then perhaps a boost to another 6 gray boost to just the bulky disease has been our practice. And rituximab-based chemotherapy, not more than 3 cycles, sort of like a non-Hodgkin lymphoma, manner, has been done in our center, but really for patients who have bulky and B symptoms. But I would reference NCCN as a good guide to help you kind of steer in that direction. But radiation alone for non-bulky stage 1 or contiguous stage 2, you can. The other thing that we encounter quite a bit, no matter how rare the disease is, non-contiguous stage 1 or non-contiguous stage 2. So, for example, you can have a patient with an axillary lymph node on the left and axillary on the right, and have stage 2 disease, non-bulky. We've done radiation 30 gray and 30 gray, and that's, but remember, follow them long term. So 10 years, 15 years is not, is not, you're not done yet. So relapses in Hodgkin relapses, non-Hodgkin relapses can happen. So keep a close eye for a long time.
Thank you. The next question was related to the recently published the Italian study by Galabini et al. HD0607 in JCO, where they mentioned that for Hodgkin, bulky mediastinal disease of any size 5 centimeter to greater than 10 centimeter, the negative PET after 2 and 6 cycles of ABVD, they do not need radiation. Any comments?
Yeah, so so that, I think in that setting, after 2 cycles, so remember, I think if you look at patients who have unfavorable risk disease, or advanced, the bottom line, so if you sort of go back to the patient with early stage disease, unfavorable risk, remember the margin of benefit is about 2%, 2 to 3%. So we're at the point where under 5% absolute benefit in progression-free survival. Remember, the endpoint of that recently published is progression-free survival. And so even with bulky disease, even in the early stage patients, you have a sign that perhaps there is some systemic disease that is either unknown or undiagnosed, and the risk of systemic relapse is higher than the risk of local relapse. And I think that's what you're uncovering in all of these studies. So when that risk, you have to risk estimate the risk of local relapse, regional relapse, and systemic relapse. It just happens in those studies, the risk of systemic relapse is actually higher than the risk of local regional relapse. Thus, the benefit of radiation is questioned, rightfully questioned. So I think, all these studies need, I think what we need to do is dissect them further for their sites of relapse, patterns of relapse, would they have relapsed in the site, would have been radiated or not, and that will give us more insight.
Thank you. The next question is, what is your comment on persistent soft tissue mass without any PET uptake in mediastinum? So after chemotherapy, if there is no PET uptake, but there is a persistent soft tissue mass, what is your recommendation regarding radiation? Do you
persistent soft tissue mass in the, so a persistent soft tissue mass in the mediastinum, historically over 2.5 centimeters of a CT-based mass, even if PET negative, it is hard to exclude that, and unless the anticipated adverse toxicity of including it would outweigh the risk of including it, the benefit of including it, I would include it in my treatment volume. Often, and some of you have worked with me know, is we will, even in the CTV volume, we may even include some of the normal large vessel that it adhered to, just because of risk of microscopic disease. So in the mediastinum, if you have persistent disease, it is likely originally PET positive and should be included in the current CTV. If it was originally PET negative, I would question that mass altogether.
Great. There is a case scenario, a 30-year male with mixed cellularity stage 2B, predominantly left cervical nodes and some small right hilar nodes. Post 4 cycles ABVD, there is no contralateral hilar node, and he received ISRT of 30 gray to left neck only. Now 3 months post radiation, he has now a 2 into 2 centimeter Deauville 5 right internal mammary node below previous radiation field. So what should be your recommendation?
So, I'm assuming the patient has all modern imaging, with PET. So in the event, so that's a good question. In the event of a localized relapse, in a young patient, the salvage options are important to consider. And all of those options could be one or more of the following. One is autologous stem cell transplant, high-dose chemotherapy, with peri-transplant radiation, either pre or post, based on response. You could use chemotherapy that helps with the stem cell and assess response and do radiation in the interim. The other is to do radiation alone in a young patient who would otherwise tolerate any salvage therapy probably quite well. And you could radiate and give chemotherapy because, received probably abbreviated chemotherapy previously. I would, using radiation alone as a modality is a scary thought. There are several series looking at localized relapses treated with radiation alone. I would proceed with that with very extreme caution. However, I think adding systemic therapy in the form of a transplant with high-dose chemotherapy would be the standard of care in many large academic centers. And adding radiation, if it's a bulky, relapse, adding radiation prior or after is a good idea.
Thank you. So what is your comments on the newer treatment approach for early favorable pediatric Hodgkin, where people are nowadays preferring more of chemotherapy and trying to spare radiation?
Yeah, so as part of the Hodgkin Steering Committee and COG, this has come up quite a bit, and most current studies, as adult Hodgkin lymphoma trials worldwide, we have, there's a movement towards immunotherapy, targeted therapy, and it's really not to replace radiation, but unfortunately what has happened is we have now come to a point where we may only be radiating Deauville 4 and higher. And many radiation studies, the studies that have randomized, the COG studies, the early COG studies have randomized patients to radiation or not, have found the benefit. And so the issue is the Deauville score and the cutoff. So what is happening is we are seeing less patients, but because we have to remind the hematology oncology colleagues that our treatment is getting better. I mean, look at your background. You have very fine tools, right? You have proton therapy, you have Rethel techniques, you have image guidance, you have other techniques that are minimizing toxicity in volumes and doses. And so treating 21 gray to a Deauville 4 spot is going to be different toxicity than otherwise. But I think we are still in the platform to treat. I think all of the COG members do recognize radiation as an important modality. So, we still will be part of the combined modality therapy approach. And I don't see otherwise. I don't see immunotherapy or targeted therapy replacing us. Just we may augment the effects.
What is your comments on completely resected stage 1 NLPHL in pediatric age group? Do you follow wait and watch?
Yeah, wait and watch has been the standard of care. And I do remember being in the meeting when that was decided as the protocol standard of care. There were some hands that went up, and I was one of them. And we'll see in time if that's okay. I think we know from some of the data from the adult literature from follicular lymphoma, from even the 4 gray studies from follicular lymphoma, complete excision is not always the cure. Microscopic disease may still be there, But I think we have unfortunately, it will take us 15 to 20 years to know if that's okay. But I'm okay omitting radiation from those patients, especially when they're young and it's in a critical site like the neck or the mediastinum or groin in young children. But that is the standard of care right now.
So how do you follow up the young female patients receiving radiation for mediastinal lymphoma, and how do you assess the risk of breast cancer? How do you screen them? What is your recommended screening protocol?
So that's a really good. I know all of you have probably a very high volume center, so screening becomes and screening and follow up is something I've learned from Dr. Manel and others I see that we've kind of worked together and collaborated. And follow up is tricky. Follow up is hard in your country, in your setting. And follow up is hard in our setting, but it's really important for secondary effects. I think in the last couple of slides, slide 67, I would just refer to. I've kind of adapted that from the NCCN, but I really I would recommend for female screening for mammogram or MRI. So the key is annual breast cancer screening 8 to 10 years post therapy or the age 40, whichever comes first. So if you have a 30-year-old, it's going to be 38 to 40. If a 25-year-old, it's going to be much sooner than that, and that's where MRI might become helpful in the right patient. So that's really, anyone who's received chest radiation, that's been our standard.
That's great. Can we use any sort of cardiac imaging which could predict long-term cardiac morbidity in mediastinal radiation group?
Yeah, so there are several studies ongoing looking at, it is really, if you look at the breast cancer world, they have done a lot of excellent work, because if you look at the population, they get radiation towards and around the chest. They have anthracycline-based chemotherapy. And so some of the studies looking at calcium scores and other scores, other surrogates for cardiac morbidity are under investigation. Some of my colleagues at UPenn, Mayo Clinic, we have participated in some studies where we are looking at different surrogate markers. Now, remember, aside from invasive coronary assessments, we have to look at surrogate markers like calcium scores. And so we've sort of borrowed that from the breast cancer world, and there are some investigations on that. There's other, in fact, there's actually data accruing about gating with ECG gating therapy. So a lot of exciting things going on. ECG delivered gated therapy, not just breath hold. So these are very, very fine-tuned adjustments to our radiation delivery.
One last question. So if there is a patient with stage 3 disease, but who underwent surgery for some reason for the nodal disease, and it becomes a case of Hodgkin after HPE. So what do you suggest when the patient achieves a CR after chemo? Do you still recommend the radiation or what?
So yeah, so that's not common, but if one was suspecting perhaps in the abdominal region, a retroperitoneal region, a sarcoma or some other disease entity, and resection was done, really the indication that patient would not receive radiation in most of the pre-PET or post-PET era studies that investigated advanced Hodgkin lymphoma. And they undergo and tolerate good, robust chemotherapy regimen and have a CR elsewhere. I don't think that particular specific patient would require radiation.
That's great. That's great. And so we are done with the questions.
So, I didn't include in the last slide, I should have left my email on there. If there are, I see lots of folks who may have questions. You can email me if you want.
I can forward those to you.
Yeah.
Yeah.
And
any comments?
No, thank you so much. It's really an excellent opportunity, and I saw at some point 150. I'm very gracious to help, to touch 150 people, and especially in this time, in this world. And I think it must be like 9 to 10 p.m. some places. And
it's almost 9:30.
Yeah, so it just shows, and there's still 82 people. It shows your, all of your dedication to, your patients, and it's just noontime for me, so I'm just it's just work. But if anybody has questions, and if I don't know the answers, we can find the answers for you.
Thank you so much. Thank you so much for taking up your time and teaching us a lot. And
Email ID, please.
Yeah,
My pleasure.
yeah, the email ID will be shared. Thank you so much.
Thank you
once again, and have a good day. Good night, everyone, and good day to Dr. Parikh. Yeah.
Thank you. Thanks.
Bye.